done this. I'll try to make sure I get all that straight before we start. So if we could please, we're now recording. And again, if you could please state your name before you speak so we have it on the record. We will also be transcribing this. Awesome. Okay, next slide. So today we are hoping to accomplish several things. The first is this first welcome and some opening business. The next will be patient perspectives presentation on emergency supply. Donna will be kicking that off and then turning it over to Kevin. Then we will talk about the short-term emergency supply comparison grid. Haley from the center will be able to present some of the information they have been able to gather for us. We'll take a quick break, and then we'll be doing an overview and some discussion. Mike Bonetto, also from the center, will be leading us through that. So in terms of opening business, we got the recording in place. Also, I would like to welcome Tim Lynch, is it? Is that the right name and pronunciation? Okay, terrific. So Tim, if you wouldn't mind saying hello to the group and introducing yourself.
Yeah, good morning, everybody. My name is Tim Lynch. I am a member of the Washington State Pharmacy Quality Assurance Commission and eager to be part of this group.
Awesome. And so, Tim, when we all introduced ourselves, we said where our dream vacation was going to be. Now, of course, you won't understand that, or you won't have that whole knowledge for everybody else. But if you would like to share what your dream vacation spot is, that will give the group a little bit more understanding and context of you as a person as we work together on this very important issue.
Ah, wow, that's a tough one. First thing that jumps to mind is maybe Budapest. I would love to go to Budapest.
Awesome. All right. Well, welcome, Tim. It's great to have you with us. And I think with that, Nonya, Lita, oh, I think this may also be Jane Byers' first meeting. Jane, if you could please introduce to yourself, give us a chance to meet you as well.
Hi, everybody. I'm actually sitting in for Barb Jones, who is usually OIC's representative on the work group, but she is out of town today.
Very good. All right, Jane, would you like to share your dream destination?
Anywhere as long as I can be on my bike.
Okay, very good.
And Mary, I just want to say that we do not have anyone representing the Association of Washington Health Plans at this time. Our member left that association, so we're looking for a new representative.
Very good. Yes, Chris Bandley has taken a chance for a new opportunity, and so and Lita, I have the name of the person who is now in that role, so I will make sure I get that to you. Awesome. Any other opening business? And Nonya, you have taken roll for us.
Yes.
Awesome. All right. Thank you so much. Okay. So with that, I think we're ready to move on to our first presentation of the patient perspective. So Donna, would you like to kick us off on this?
Sure. So we wanted to make sure that we have the patient's perspective when we're working on recommendations to provide back to the legislature. And so we asked Kevin Wren to help us with bringing patient perspectives on the emergency supply to us, and he has prepared a series of 5 videos, and he's going to display those. And Kevin, I'm just going to pass it off to you.
Thank you. So I reached out to a number of our chapter members just to get a rounded patient perspective. We have Jim here, he's first. He is, I think, on Medicare. He's a little older, and I'll let him kind of give his story about why we need to have co-payment caps on insulin. I mean, people are still insured, He has insurance, but he still pays the high amounts for his out-of-pocket costs. So I'll let him tell his story.
Hello, my name is Jim Cheers, and I have had type 1 diabetes for 26 years. I truly appreciate the opportunity to speak with you today about the rising cost of insulin. Even with insurance, the unpredictable and increasing cost of this life-saving drug is both frightening and frustrating to me as well as many others. Every 90 days, I need 5 vials of Novolog insulin to stay alive and healthy. My insurance copay is 30% of the list price for insulin, Novolog. Because this price is unnecessarily volatile and continues to increase, I continue to see my cost increase. Here are 2 recent examples of me refilling this prescription. What you'll see here is in June, the list price of my Novolog was $522. I filled again in September, and the list price had jumped to $1,302. That's quite a bit. That's a 150% price increase for a drug that has remained essentially clinically unchanged for the past 20 years or so. What I don't know is why, other than manufacturers and PBMs enriching themselves through the veil of rebates and formularies. Now, fortunately, my copay is capped at $290 for that increase, but that's still a double copay for me. And for folks in high deductible plans without such caps, insulin becomes quite unaffordable, forcing the dangerous practice of rationing for many. And this rationing can lead to expensive, avoidable complications and even death. So we really need a check to balance this inequity that limits how much we are required to pay in order to simply stay alive, healthy, and thrive. Thank you very much.
Yeah, that's Jim's story. It's not unique. I mean, many of us go through the same thing. The next video is of Levi Marklin. He is 10 years old. I first testified next to him a couple years ago, back in 2020. Very effective testimony. The fears of a child, rationing insulin. We can't choose this disease. It chooses us. So we're kind of stuck with it. And I think his words are very impactful, and I hope you listen to his story.
Hello, my name is Levi Markland, and I'm 10 years old. I was diagnosed with type 1 diabetes when I was 6.
What does it feel like knowing you have a disease that has no cure?
Knowing that I have a disease with no cure is hard for me because I have to deal with stuff that most people don't.
How does it make you feel when you hear about other diabetics that die because they can't afford insulin?
It makes me feel worried and sad because just people are dying because of diabetes, and it makes me worry because I have diabetes, and if I can't afford insulin, then I'll die too.
What do you want people to know about the importance of affordable insulin?
It's important because if people can afford it, more people can live and help the world.
Any last words from a superhero?
Just live healthy and happy.
That was Levi. I should underline that this insulin price crisis affects Black, Indigenous, and people of color more than white people, just because of the social inequities of our healthcare system. Social determinants of health make it harder for these communities to access affordable insulin. And so we need to work to make this kind of racist system less racist and more accessible. And the next video is of Amber Markland kind of talking about our policy recommendations for this copayment cap, and kind of the necessity of it. And yeah, I'll let her tell her story.
Hi, my name is Amber Markland, and my son Levi was diagnosed with type 1 diabetes in 2018 when he was 6 years old. We live in a country where nearly 1.9 million people live every day with a disease that has no cure. On October 18th, a statement was released saying that more than 1 million Americans living with disease are rationing their insulin because they can't afford it. Insulin, the sixth most expensive liquid in the world, sold to families like mine for hundreds of dollars. This comes at a price most average Americans cannot afford. And there is more than just insulin a diabetic needs to take care of themselves. Needles, lancets, ketone strips, alcohol wipes, snacks for lows, pumps, monitors, meters, emergency room visits, and so much more. Type 1 diabetes is unpredictable, expensive, and cruel. But to add the financial burden to that list when we sit here knowing there's a way to improve so many lives in our state is even more absurd. We all need insulin to live. The only difference is type 1 diabetics have to pay for theirs. Not all diabetics have the privilege to afford to pay thousands of dollars per month. Those that can't ration their insulin, causing severe damage to their bodies, and eventually over time pay the ultimate price by dying. Type 1 diabetics are already burdened by a disability beyond our control. We shouldn't be forced to feed the greed of pharmaceutical manufacturers and plead with gatekeepers of unjust rules and regulations in our healthcare system that the importance of accessible and affordable insulin for all is our main priority.
That's Amber, and that was amazing. Her and her son provided really poignant testimony as to why we need copayment caps. They're both insured, her and Jim, but they still have high costs for their insulins, which is unnecessary. There's no reason why we should pay so much for this drug that is over 100 years old now. And that's kind of, I'm sorry.
I'm sorry to interrupt you. Before we go to the next video, some people are having a hard time hearing the videos. So
I had this problem, and I think there's an option because it's not just your computer audio. If you click on the caret next to your microphone and go into audio settings, under there's also a separate speaker volume just for Zoom and what volume Zoom is at. And so if that volume's way down, even if your computer volume's up, it can be hard to hear. So that is another way to adjust it. At some point, mine got turned way down. I don't know why. And I couldn't hear, not on this call previously. So I figured that out.
Okay, great. Yeah, so under mute, click audio settings, and then you have your speaker and your microphone volume.
That may help too.
Thank you.
And then for whoever's projecting it, they could go in there too and turn up their microphone volume, and that might help with projecting a louder sound also.
Okay, I'm going to try too.
Thanks so much, Jenny. So Kevin, I thank you for giving us all a minute to find that next to our mute button. And if you want to go ahead, and we'll turn it back to you.
Awesome, thank you. So that kind of wraps up why, we broke it into two kind of categories, the uninsured and the insured. People with insurance are paying a whole lot of money for their insulin. So we want to make sure to cover them with a copayment cap of $35. That's kind of what Mexico and Canada pay for their insulin. So, it's reasonable. It's kind of arbitrary. It doesn't need to be $35. We can kind of choose how much, but that's that piece. The next piece is covering the uninsured. Coverage gaps can happen for so many reasons, not having insurance. So, I just helped someone just this month who is rationing insulin down on Federal Way. I brought them a box of Lantus pens, which can cost upwards up to $500. and it really saved their life. I also just heard from an advocate that she knows a stylist who was rationing their insulin and had to be hospitalized. So we're raising money for them via GoFundMe and mutual aid diabetes. This problem is persistent. It keeps getting worse. As Jim told you, prices keep going up. Formulary keeps changing the prices. So we have to have kind of a safety net for the uninsured and for us that maybe are partially insured or, you know, rationing for whatever reason. And having a 90-day supply is kind of critical. I can't tell you how many people I've helped ration insulin, like rationing insulin, provide them with insulin. And it's still technically a felony. And I'm admitting to another felony of doing this. So it's hard because the burden falls on patients to kind of scramble, and we really need the state to step in and provide a solution. Madison Johnson here, who leads Washington Insulin for All, can talk to that a little bit and talk about the reasoning behind why we need kind of an Alex Smith-esque safety net program that allows people a 90-day supply of insulin. Yeah, I'll let her tell her story.
So Kevin, before we go to the video, it looks like we have a few questions. So
yeah.
Jennifer Perkins.
Yes, hi. So I just, you reminded me, Kevin, of a qualitative study that I read recently, and it was specifically on GoFundMe campaigns for insulin. And what they had found was that GoFundMe is not an effective method for actually getting people the money that they need to pay for their insulin. A lot of them they were not successful, and they did not get the money that they needed. I just wanted to share that with the group here.
Thank you, Jenny. Yeah, GoFundMe is not a solution. It is a solution, but it often doesn't help people. I mean, I've been told to start a GoFundMe because a job was unpaid with the United States Senate. So this problem persists, and it kind of leaks into all these other things. So thank you, Jenny, for pointing that out.
And then Jenny Arnold also had a question or
Hi,
comment.
and I agree. This is not something we can allow to happen in our state. But I think when we think of solutions, and that's where we're trying to go. And I know we've discussed as a group, is the issue uninsurance or is it underinsurance? Do you, as you're going through and helping these folks, Kevin, I think similarly with GoFundMe doesn't help. You know, I mean, I think that finding a box of insulin for somebody isn't, to me, it isn't a solution, because what happens the next month and the next, right? We want to get people in either into care solutions that work and actually cover them, in my mindset. Whether that's insurance and access to care, or whether that's helping with copays or dropping the cost of copays. Do you have a sense of kind of, is it all across the board, or is there a pattern that you see where it's they don't have insurance, or there's a gap in their insurance, or the insurance copays are too high, or kind of some of the causes, I guess? Not like I agree with the problem, and I'm looking forward to hearing this next video also, but I think the root cause of it, I think, is helpful too.
Yeah, I mean, it's all the reasons that you can think of. I helped my brother, who was experiencing coverage gap because he was changing jobs and didn't have insurance for a month. I helped, I mean, the person that is in a coma right now, she has a full-time job, but she makes so much money that she doesn't qualify for the subsidies for Medicaid. So she's like kind of on the elbow there, which a lot of people are, where it's like, you have enough money so you don't qualify for Medicaid, but then like the cost of insurance is just so high that it's cheaper to pay out of pocket costs for insulin. So there's like so many reasons. I mean, not having documentation. I helped a migrant family out in Eastern Washington back in March. I've helped homeless people that have somehow gotten to us online. So like it
So it
just makes
sounds
me
like
think of,
uninsurance and
Yeah.
gaps in insurance seem to be the bigger issue versus kind of the cost of copays with a lot of the folks that you specifically are helping. It's kind of the trend that I hear, just the
But
10,000 foot view, and then the causes for the un or under insurance are varied.
but it's also
Maybe.
the insured. Like I'm helping the insured too. Like people with insurance that like their cost is just too high this month, so they have to save up for maybe buying the insulin next month, and they're just like short. But
So
then again,
deductibles are also an issue, or high
Yes.
deductible plans.
yeah,
Okay.
and just yeah, and like when we talk about kind of again those overall solutions, like expanding Medicaid to people would be a big help, and it's not directly tied to accessing insulin, but it is like one of those bigger solutions that like would help a lot of these people. I mean, it's it
Thanks.
breaks my heart whenever I help somebody, and it happens all the time. But
I didn't mean to get in before the video here. I just,
Oh,
I
here.
think the causes to me are where we find the solutions, I guess, maybe. Thank you.
Yeah, for sure. Thank you.
Do you want me to go ahead and play the other video, Kevin?
Alex Smith, John Wilkerson, Jada Renee Lewis, Jesse James Lutkin. These are just 4 people that we know out of the many who have died because of insulin rationing and lack of access to insulin. There are countless more that we don't know, or who have suffered or are suffering from complications from rationing their insulin. About once a month, advocates engage in mutual aid to provide rationing diabetics with insulin here in Washington state. With over 1/3 of Washington at risk of developing diabetes, this issue will only continue to grow and plague us. It's only a matter of time before one of us falls through the cracks and rations into an early grave. Experiencing a coverage gap can occur for so many reasons, even here in Washington state where we have great public health care. Not getting coverage, finding a provider, and getting prescribed your medication takes time, even within a system. We need a legitimate 90-day window in order to get these things established and sorted. We need unfettered access because life can throw you curveballs when it comes to your insurance, and no one should even ever have to wonder where they're going to get their next insulin dose from.
That was Maddie Johnson. I mean, kind of underlining some of the things that I said. People ration for all different types of reasons. When we look at the Alex Smith Act, I think there are aspects of it that we can improve upon here in Washington, like loosening the eligibility criteria. I think it's hard for someone who's undocumented or homeless who doesn't have an ID in order to access this program. I mean, it still helped like 1,000 people in Minnesota this last year. So there is a clear and present need for it. It's just about us making it as accessible as possible. And that means loosening all the eligibility criteria that we kind of talked about and surveyed about. I'm sure we'll discuss it more, but I mean, again, coverage gaps can happen for so many reasons. So we need a safety net. We need something to help the insured afford their insulin if they have high deductibles, and we need something for the uninsured or people that just can't access their insulin for whatever reason. And like a 90-day supply is a really innovative idea, and I think it improves upon the Alex Smith Act. It can take weeks to get in to see a provider, months. and then get that prescription and then get to the pharmacy, all while like navigating your life and trying to afford other things. So having that bigger window is really critical. Loosening the eligibility criteria is also really critical too, in helping these people that are rationing. But then that'll go into kind of our third policy topic with Jenny. We tried again to take a broader view of what providing this insulin would look like for the insured and the uninsured. Like how would the healthcare authority leverage kind of existing systems, or potentially work with California, who's looking at manufacturing their own insulin or distributing or partnering with somebody to do that. So there's some pathways for us to source this insulin and find an affordable way to provide it from the state. But I'll let Jenny kind of talk about that.
Hi, my name is Jenny Perkins. I think it's really important for us to think of resiliency and incentives in our pharmaceutical system. It has been said time and again, the three main companies have unethically and artificially increased their prices in lockstep with each other. Solutions involving multi-state compacts, including ArrayRx and California's public production, would be a vital solution to uninterrupted and affordable supply of insulins that people use to sustain their lives. We live in an uncertain time. If something happens to just one of these companies or something happens in the supply chain, there could be devastating effects. Having more suppliers adds resiliency and incentive to lower prices in our supply chain. Lately, I've heard that people think that the older insulins are just as effective as the newer analogs, and that simply is not the case for me and for many other diabetics. I felt really scared when I had to use regular insulin. It is not approved for use in insulin pumps, which also makes it a poor option for people like me. One study I saw, published in JAMA, switched over 14,000 people to older insulins and didn't ask what that experience was like for them. They didn't follow up on the 15.7% of people who were not included in their analysis because they switched back to their normal regimen within a year. I presume they switched back because it simply was not effective for them. And a study that only includes seniors, less than 1% of people with type 1 diabetes, doesn't really represent the population of people with diabetes here in Washington state, and therefore it should not be generalized to us. We should not let pharma, PBMs, insurance companies, or anybody else decide our medical treatments based off of what is most financially best for them. Which medicine we take should be based off of what is best for our health and our future. Adding ArrayRx and the California production to the table could provide a transformative solution that as a type 1 diabetic I can get behind. We should not settle for substandard insulin. We are not even asking for the latest and greatest drug here. Many of these analogs are over 20 years old, and we all know that the US pays more for drugs than other countries do. We ought to stop letting them get over on us and oppressing people with diabetes. 1 in 10 people have diabetes, and 1 in 3 seniors do. It is common. Diabetes is a common variation of the human condition, and we deserve to be treated as humans, not as consumers to be capitalized on. Money saved by utilizing the methods I mentioned are one option that could be used to reimburse pharmacies that supply emergency insulin. Thank you for your time.
Yeah, thank you, Jenny. And Jenny's on the call too, so hi, Jenny. I think her testimony is great, and it really speaks to some of the issues we've seen, especially, I mean, even within this group, I think we've kind of touched on it, is leveraging kind of Walmart insulin and regular insulin as a solution. I know for a lot of people that doesn't work. It doesn't work for me. So we need to have access to the medicines that work best for us. That means not limiting which insulins are provided in the supply. We need to have access to the latest and greatest short-acting insulin, which has been on the market for 30 years. I mean, I could talk about how they've rigged the system, but I think Jenny did a great job of telling us why we need access to this program and how the state can leverage kind of Array RX to source this insulin. Yeah, and then my final piece, my video here is about kind of next steps with this group and where we see it going. I think we recommend creating a department within the state to address insulin affordability and hire 4 full-time employees, someone to manage the group and kind of oversee some of the recommendations that we've provided in this group. Yeah, I'll let me take it away.
To address insulin affordability, Washington needs a team within the state government and healthcare authority to address insulin access on a committed, full-time basis. To achieve this, we recommend creating a Department of Insulin Access with 4 full-time employees within the healthcare authority. This crisis cannot rely upon unpaid advocates to engender change alone, and this requires a full-time commitment from the state. Implementing co-payment caps for the insured, creating a safety net program offering an emergency 90-day supply of insulin for the uninsured, and sourcing insulin to mitigate high costs all require dedicated staff. It was advocates like myself that ushered this work group into formation, and we recognize our state does not have the bandwidth for a dedicated response to address the insulin price crisis in Washington alone. So, creating a department to focus on access is the next logical step beyond this work group. States must band together to address the high cost of insulin, albeit through Array RX or California potentially distributing a low-price generic, and our state needs the people power to make those connections and build those bridges. They can also help explore other aspects of the crisis, like accessing supplies and technology, and working with advocates to determine the needs of the community, as well as working with industry individuals to negotiate access. We need a perennial solution to this crisis because our diabetes isn't going anywhere. The high cost isn't either. And with our help, we can create a long-term solution that seeks to create enduring safety nets that save people's lives and prevent us from rationing our insulin. Thank you.
Yeah, and that's just kind of taking this group to the next step in our recommendation to the legislature. Kind of how does this get done? Establishing co-payment caps and overseeing a safety net program, I think takes full-time people, and I'm sure our healthcare authority people on the call, being divided between your work is tough. So just having a department there, I think, is necessary. I don't want to have to keep doing this as an unpaid advocate. It's really not, it's a public failure and we need to step in. I think covering the uninsured through a safety net program like the Alex Smith Act and expanding it to 90 days is perfect. Having co-payment caps is also great. It'll help people, afford their insulin and focus on something else. $35 instead of $300 is a huge difference, especially for someone on a fixed income or, have other payments like car payments or whatever. So I think we've discussed all the reasons why we need these programs. It's just kind of fine tuning them at this point. But thank you.
Excellent. Kevin, thank you so much for the presentation. And we'll give it a minute for questions. And just a quick reminder, as you start to speak, if you could please state your name. So again, thank you so much, Kevin.
Hi, Mary. This is Donna Sullivan. So I have a question. You keep mentioning copay caps, and Washington State Legislature passed copay caps, I think twice now. I thought it started in 2020, and it also applies to high deductible plans. So have you seen, are you hearing people still being charged a high copay in the last year? Because that's a regulatory issue with the, the Office of the Insurance Commissioner. And I think maybe Jane can jump in and correct me if I'm mistaken.
I'm still hearing it from people. There was an advocate that wanted to testify about it because the insulin for her child is still super expensive. I mean, Jim pays 30% of the list price, so it's like people like Jim and people with insurance are still seeing this stuff. I mean, I get asked, like, I think at least once a month via Facebook or Twitter, and I have to keep reminding people that this group is making a recommendation to expand maybe those copayment caps that already exist and like explore regulatory things. But I think at the end of the day, it's like there's only so much we can do as advocates. So like if it is a regulatory issue, we have to create something within the healthcare authority to address that.
So Kevin, this is Jane, if I can jump in. And Donna, you are correct that for health plans that we regulate, that the state can regulate, which are fully insured health plans, that cap on copays applies. But under a federal statute called the Employee Retirement Income Security Act, lovingly called ERISA, states cannot regulate self-funded group health plans. The only self-funded group health plan that the state can regulate is our own uniform medical plan because it's our plan. And based upon national estimates that we've seen of people who get their coverage through their employer, which is probably upwards of 4 million people in Washington state, about 2/3 of those employer-sponsored plans are self-funded. So Kevin, it doesn't surprise me at all that you're hearing from people who have insurance, especially large employers are more likely to self-fund. So it doesn't surprise me at all that you're hearing from people who have really high cost sharing for their employer-sponsored plan, because more likely than most likely, it's a self-funded plan that we can't touch. And many of you probably remember that the Inflation Reduction Act tried to apply that $35 copay to all health plans, but the Senate parliamentarian ruled that you couldn't do that through budget reconciliation. So it's still a real issue for folks who have self-funded health plans.
And
so it only ends up being about 1 million people that are impacted because it's also not Medicare. Medicaid's covered, luckily, but that's that challenge, just to round out the discussion, because we've had that issue on other pharmacy issues.
Yeah, and fortunately, the Inflation Reduction Act does apply the $35 cap to Medicare. So thank God, Medicare beneficiaries. There are about 1.5 million Medicare beneficiaries in the state. There are about 1.3 million enrolled in the health plans that we regulate. So there's probably close to between 2.5 and 3 million people in the state that get their coverage through self-funded employer plans.
Thank you for that.
And then I saw Lugina had her hand up. Do you have a comment?
Oh, yes. No, I was just going to ask, I wanted to clarify and make sure that the federal Inflation Reduction Act would impact those with Medicare. I just want to make sure that I wanted to confirm that was accurate. And I think Jane just included that in her comments. So thank you.
And then Laura, I noticed you had your hand up. Did you have a comment as well?
No, I was just gonna say basically what she said. This is Laura from the American Diabetes Association. About those are ERISA plans, and we unfortunately don't have the ability to regulate those on the state level. And I do Hope that at some point we'll be able to make change federally to address those things, but you're exactly right. There's a lot of ERISA plans and companies that choose high deductible plans intentionally, and when they choose those plans, that's what happens with high deductibles and people not being able to afford their insulin in the state of Washington. And it's unfortunate because this group can't regulate that through a copay cap in that way, in the same way that you do private insurance that the state can.
Thank you for clarifying that and reminding us of the ERISA plans. Any other discussion or conversation, questions that we want to document or share?
Oh, and I just want to say that I've been in like conversations with the White House and Senator Schumer about potentially doing a federal price cap on insulin, and that's still a ways off. So don't hold your breath for that.
Yeah.
Great. Well, Kevin, Donna, everyone, thanks so much for the great discussion. Really appreciate having that deep understanding of the patient perspective, as well as the solution oriented approach that you are taking on this. It's very helpful. So with that, and of course, we will be with each other for the next hour and 15 minutes. So if we think of additional questions, please feel free to put those in the Q&A, and we'll make sure that we capture those and are able to continue this rich conversation. But with that, let's go ahead and move on to our next agenda topic. And Haley, I think I'm turning it over to you.
Sorry, got to get off mute. Thank you, Mary. My name is Haley DeCarolis. I'm a policy analyst at the Center for Evidence-Based Policy. And today I will be presenting an overview of the state policies we found for emergency supply insulin legislation that we've talked about in previous work group meetings. And I just want to mention that this slideshow or this presentation is focused on short-term solutions and policies. So strictly emergency supply. We are planning on future meetings covering long-term solutions, and some of these policies do include a long-term aspect, but we won't be focusing on those today. I just wanted to start off with that note. Next slide, please. These are the four different policies we'll be going over today, and they all have been implemented in the last couple of years, and some have been brought up in discussions already. Next slide, please. We are going to start with the main insulin safety net program. Next slide. This was signed into law June 21st, 2021, implemented a couple months ago, March 1st, 2022. So the full policy does include an urgent need safety program, and also an ongoing assistance program through the manufacturer. It is funded partially by insulin product registration fees that are levied on the manufacturers, and it requires annual reporting to the legislature. The urgent need program provides 30-day supplies. So this is different than what we've heard in the work group related to the 90-day recommendation. Next slide, please. So I wanted to highlight some key definitions from this state program. It doesn't specify any certain type of insulin. I know that's come up in the discussion before. A manufacturer is subject to the program if they have an annual gross revenue from sales of $2 million or more annually in that state. So this would be in Maine. And they classify urgent need of insulin as having less than 7 days of insulin available and being in need of insulin in order to avoid the likelihood of suffering significant health consequences. So we can kind of talk about later how that's determined, but that is the key definitions for this policy. Next slide, please. And then to be eligible for the urgent supply program, the patient must be a resident of Maine and they must be able to present documentation of this. So that's another item that's come up in the work group discussions as kind of a limiting access. They cannot be enrolled in Maine Care, which is their Medicaid program. They cannot be enrolled in healthcare coverage that limits cost sharing to $75 or less for the 30-day supply. Their household income must be lower than 400% FPL, not eligible for federal healthcare coverage, and then some specifications around Medicare Part D and the spending on that. Next slide, please. So important part of this program is the application process. So the Board of Pharmacy with the state must post an application online, as well as have it be available in various healthcare settings. And then on the application, the patient is responsible for demonstrating all eligibility criteria, which means bringing in proof of Maine residency. They will bring this completed application to the pharmacist, and then the pharmacist is responsible for reviewing the application at the time that the patient is requesting the emergency supply. This is different than the ongoing patient assistance programs required by the manufacturer, where the manufacturer is responsible for receiving and reviewing the application. For the urgent need, it falls to the pharmacy. And at the time that the patient is submitting the application and requesting the insulin, the pharmacy must also supply them with an information sheet about their health insurance consumer assistance program, which includes programs like ongoing insulin assistance programs, information on how to apply for Maine Care, information on providers that participate in prescription drug discount programs, and other assistance programs through nonprofit organizations. So they get an information sheet with all of those resources at the pharmacy. Next slide, please. In order to access the emergency supply, the patient must present the signed, dated, completed application, a valid prescription, and a Maine identification to the pharmacist. This next bullet is an important distinction between Maine's program and Minnesota's program, which we'll go over next. In Maine, if the patient does not have a valid prescription, the pharmacy may still dispense the insulin. And then one thing that's not noted on this slide but is important is that access is limited to a one-time supply over a 12-month period. So they can only get the emergency supply once in a 12-month period, which is pretty standard across the different emergency programs. Next slide, please. So moving on to program monitoring, the safety net program requires annual reporting from manufacturers, which includes how many people access the insulin, how many people are participating in the ongoing assistance program, and then the value of the insulin that was dispensed. The state pharmacy board aggregates this data and submits it annually to the state legislature. And then for tracking purposes, the pharmacy must retain a copy of the application form. And they also must notify the original prescriber of the dispensed insulin no later than 72 hours after. The timeline for this varies between the emergency programs, but I believe all of them do require the pharmacy to notify the prescriber at some point. Next slide, please. So for reimbursement, Maine pharmacies may charge up to $35 copay for the 30-day supply, and that's to cover the pharmacy's costs of processing and dispensing the insulin. But the manufacturer is responsible for reimbursing the pharmacy for any dispensed insulin. They can do that either with replaced supply or through an electronic claim in the value of the insulin, which is meant to cover the pharmacy's acquisition costs. So it's important to know that this is on the manufacturers to reimburse or give replaced supply. Next slide, please. So then part of the funding from this program comes from the annual licensing fee that is assessed on manufacturers that have an annual gross revenue of $2 million or more. So each manufacturer that meets that criteria must pay $75,000 annually. They're also responsible for backfilling the supply or paying the claim, although there is no specified timeline for reimbursement by the manufacturer. The manufacturers must also establish the ongoing patient assistance program. They're responsible for approving or denying applications for that program, and then they're also responsible for submitting data. So this is the licensing fee, the $75,000 fee is unique to Maine's program, and it gives them revenue to support the program. Next slide, please. Okay, moving on to Minnesota's insulin safety net program, which is named the Alex Smith bill, which Kevin has mentioned in this meeting. It was signed into law in April 2020, implemented July 1st, 2020. It's very similar to the Maine program, although there are a couple of distinctions. So it's the same in the sense that they have an urgent need program, continuing ongoing patient assistance program reports. In addition to the Maine program, they also did a program satisfaction survey for the first couple, or for the first year, because it was submitted to the legislature last year. And that it surveyed the patients, providers, pharmacies. So we'll get into that a little later, but that's a distinction. And then same as Maine, it provides 30-day supply is the emergency supply definition. Next slide, please. So to be eligible for the program, the patient, very similar to Maine, must be a resident, must not be enrolled in their Medicaid program. It has the same cost sharing limitations. Same access is restricted to one 30-day supply per 12-month period, and they must demonstrate an urgent need for insulin. Next slide, please. And this program does have the same application process. The development of the application is a little bit different, but it must be available at all the same places. The pharmacy, again, is responsible for reviewing and determining whether the patient is eligible at the time that they're requesting the emergency supply. The only difference in this one, which is not related to the emergency program, but for the ongoing assistance program, this bill specifies that the manufacturer has 10 business days to review and approve. That was not in the Maine bill. And then like Maine, the pharmacy must also provide an information sheet with resources. Minnesota also provides trained navigators. They have an appropriation that's used to train the navigators in helping patients access different assistance programs for insulin. And so that information for the trained navigators is included at the time of application. So another distinction from Maine. Next slide, please. Similarly to Maine, the patient must present the signed and dated application, valid prescription, and then proof of Minnesota identification at the pharmacy. Unlike Maine's law, the patient is required to have a valid insulin prescription. So that's another point of distinction between the two programs that we could consider. Next slide, please. For program monitoring, again, very similar. The pharmacy must retain a copy of the application, alert the prescriber. Manufacturers are reporting the same information to the state as the Maine program. Reports are aggregated annually. And then there was a program satisfaction survey that was submitted January 15th. That's not a public report, but that was another program monitoring aspect of this program. Next slide, please. So next, we're going to talk about the Utah amendments. This builds upon the Utah Insulin Access Amendments that was passed in 2020, which we've talked about a little bit in this work group. But this was an amendment it passed or effective in May. And we're going to get into the specifics on the amendment, but I wanted to just kind of set a base for what this is building upon. So the Utah Insulin Access Amendments in 2020 provided an incentive for health benefit plans to reduce their co-payments. And again, this is similar, I believe, to our discussion earlier about how there are exemptions to that, but the state regulated plans were capped. It required a study on insulin pricing, and then it also created an insulin discount program that allowed Utahns to purchase insulin at a discounted post-rebate rate. So kind of increasing access to discounted insulin was that program. And then authorizes a pharmacist to refill an expired insulin prescription. That's what we're going to be talking about today with the updated amendment. Next slide, please. So eligibility for getting an emergency supply. And this program is actually prescription specific, not based on the patient. So the patient must have an exhausted prescription, which means a prescription for insulin that the patient is currently using that is expired no earlier than 6 months before the request and is not expired or has no refills remaining, fully expired, I guess. A pharmacist may dispense emergency supply no more than once per exhausted prescription. So similar to the other programs, there is a cap on how many times this could be accessed. Next slide, please. So the pharmacist may dispense the emergency refill for the exhausted prescription. This is in an amount up to 60 days. So this is different than the other programs that have 30 days. But before dispensing the emergency supply, the pharmacist must attempt to contact the prescriber, notify the patient of that contact, and then inform the prescriber of the insulin that was dispensed within 30 days. Another important distinction of the Utah program versus the others is that the pharmacist may dispense therapeutic equivalent when filling a prescription, and they're able to dispense diabetic supplies. So I thought this was important to highlight because it is different than the other programs, and it's a concern that has come up in the work group. This is the only piece of legislation I found that lists the diabetic supplies outside of just insulin. Next slide, please. So this program is not funded by manufacturers. So there's no requirement for manufacturers to backfill the supplies or pharmacies to bill the manufacturers for the dispensed insulin. So there's no language in the statute related to reimbursement, copays, or insurance. So it's really just an emergency access without being working with the manufacturers to kind of fund or finance in various ways. Next slide, please. So then finally, we're going to move on to Ohio's House Bill 37. This was implemented June 1st, 2020. And this is not specific to insulin. This legislation expanded the emergency dispensing authorization to up to 30 days for all non-controlled medications. So it allows, the only legislation we've highlighted that is not insulin specific, but would cover insulin. Excuse me. This is for all non-controlled medications and allows the pharmacist to dispense the drug without a prescription if the pharmacy has a record of a prescription. And the pharmacy is unable to obtain authorization for a refill, and the pharmacy is responsible for determining if the drug is essential to sustaining life. And the other criteria is that the failure to dispense the drug would result in harm to the patient. So again, just wanted to highlight that there's no specific language related to insulin, but it is covered under this proclamation. Next slide, please. So all insured patients are eligible. This is not targeting the uninsured population. You're also required to have a prescription at that pharmacy. So that's another consideration for patient access. But unlike other programs that limited access to a one-time 30-day supply in a 12-month period, this legislation allows for the drug to be dispensed up to 3 times. After the first 30-day supply, it's 2 supplies of 7 days only, but it is more than the other programs had in their policies. Next slide, please. So for patient access, the pharmacist must not be able to reach the prescriber, and it's on the pharmacist to determine if the patient is indeed in need of emergency supply. Coverage and copays for emergency supply are the same as when insulin is dispensed in non-emergency situations. They won't be charged differently in this if it's an emergency or urgent need. So really, this policy program does not address the affordability of insulin, but rather the emergency access piece that we've talked about in regards to the short-term solutions. Next slide, please. For program monitoring, the pharmacy must keep a record of the emergency supply for up to 1 year and notify the prescriber, but there's no annual reports required to the legislature like we saw in the other programs. Okay, last slide, I think, is just a quick highlight of all the four different programs. You'll notice Minnesota's box is pretty small because it's very similar to Maine. So you can kind of take that as those two have similar elements. I think we have some time to have a short discussion about these 4, if anyone. I know that this was part of the survey that you all received. And so we've gotten some feedback on this, but if we have, I believe we have some time for a short discussion if anyone would like to share their thoughts.
Great, thanks so much, Haley. And I see Legina's hand is up. Legina?
Good morning. Thank you again. This is a really great overview. I appreciate how you approached the overall program and different ways that states have approached this. One question I have in the Ohio bill, and then you talked a little bit more about how pharmacists were allowed to dispense emergency supplies and whether a prescription's expired or not, or in various situations. I wondered, since Tim and Jenny are on the phone, who are both pharmacists in Washington, can you share with us what Washington state law currently allows pharmacists to do when facing similar situations?
So I'll tag team with Jenny. So just to be clear, in the case of a patient who needs an emergency prescription, whether or not a pharmacist could dispense that without a new prescription in hand, is that what the question is?
That's what I was asking, because I'm a pharmacist as well, but I practice in other states. I practice in other states, and I know like it varies state to state what you can do, like if it's a control versus a non-control, and you know, things like that. So I just wanted to see if you could help us just get a baseline understanding of what is currently allowed in Washington, help inform us of the solution.
Yeah. So if a patient shows up with, it would be under the professional judgment of the pharmacist to be able to dispense an emergency prescription. Generally, they would like to have a prescription on file if it has expired, and they would reach out to the prescriber, but they can give a temporary supply to cover the patient in order to ensure that they have the medications needed for their self-care.
Okay, and is the temporary supply, is there like a day limit? Like, for example, I know they talked about a 30-day supply and a 90-day supply in some of these instances. Is there anything like, because I know in New Mexico, where I first started practicing, you know, we had like a 72-hour supply where you could do something to get somebody emergently over the hump, but I didn't know if there was anything like that in Washington.
Yeah, you're really testing me right now. I'd have to. I'll have to go back and review the law of. We went through a rule rewrite recently, and I'll have to go back and look at it. I don't know if Jenny has it top of mind. I can try to do that maybe over the break and give you the details, but generally, I mean, it would be hard to give a 72-hour supply for, you know, with a vial of insulin. Right. So I think, I think generally, and I would say the patient's safety and health is paramount in these situations. And so I think that would be certainly a consideration that practitioners would need to take into account in terms of providing care. I don't want to speak on behalf of the Pharmacy Commission, but I think, you know, as a clinician, you know, caring for the patients, you have to, the patient needs this in order to survive. So I think there would be that acknowledgement. So.
Right.
Tim, thank you so much. And
I apologize for putting you on the spot. I just wanted to see if you knew offhand, so I apologize.
No. It's, yeah, I'm just thinking of the old laws and our new, and I'll have to go and do a double check. I don't know if Jenny has it top of mind or if she's still on.
For emergency prescribing?
Yeah,
Jenny Arnold, yeah.
Yeah, so Jenny Arnold from the Washington State Pharmacy Association. Our state law does have a provision like Utah's where a pharmacist can refill even an expired insulin prescription as long as either they filled it or they have kind of medical proof. So a patient couldn't just walk in and say, I need insulin, to pharmacies they've never been to. But if they go into, you know, I fill their prescription regularly and the prescription's now expired, I can provide them a 30-day refill of their medications. And Tim, it was part of our rule rewrite that you led, and it was for exactly this issue because our previous state law allowed for a 72-hour supply, which doesn't really work for getting you an insulin vial. And so we rewrote the law so that it allows this flexibility to be able to do that. So that one we've got covered in Washington.
Fantastic. Thank you, Jenny.
Hey, Jenny, this is Mike. Just a quick follow-up on that, though, just so I'm clear. Is there any copay provision around that? What does that look like?
They would run it through the insurance. So there's two issues when you talk prescriptions. There's the legal authority to fill a prescription, and then there's payment for the prescription. So the pharmacist can extend that prescription. So there's the legal authority to dispense that prescription. You know, there is a prescription there for that prescription agent or product. And then it would be run through insurance. The same. So it's not a cash pay. It'd be just like you refilled your prescription. Basically, the pharmacist is extending that expired prescription for another month. So it could be run through insurance and all that.
Thanks, Jenny. Assuming they had that insurance.
Yeah, there's payment, and then there's the prescriptive legal authority to dispense a prescription medication. So the state law allows for that legal authority to dispense that prescription. That's separate from payment. But if they had insurance, it would be run through insurance, and copays would apply and all that. So it's only half, part of the battle, but I think it's an important continuity piece.
Correct. Thanks, Jenny.
Thank you. Yes, Jennifer.
Yes, this is Jennifer Perkins. I had two things. One, I believe my comments only get into the transcript if I state them. So one, before I say my question, I wanted to read what I had written, since we have a moment. Imagine if you had to do all that we have to do in order to get your life-saving water. Find a specialist, wait for an appointment, pay for appointment, take time off of work to go to see specialist, go to pharmacy, hope there are no issues, pay your portion, which varies and may be unreasonable for your essential water. You must get a prescription every year, even though you will need this water for the rest of your life. I was just trying to help folks understand what this would be like, because I think that insulin is pretty synonymous with the need for water and how we need water every single day. But I did have a question specifically. I'm not sure when exactly this 30-day emergency supply rule that you're talking about went into effect. I'm just curious of how pharmacists are, if all pharmacists are aware of this, if there's like some way that everybody was told and understands what they are able to do and what they're not able to do, just because I know there's so many rules that I worry that perhaps not everybody would necessarily be aware of the rules and be able just to help patients if they're not aware.
Okay, Tim and then Donna.
Yeah, Jennifer, this is what Jenny alluded to is we went through a rule rewrite, about a 2.5-year project with the Pharmacy Commission, where we redrafted all of our rules, and those came into effect about 1.5 years ago. And at that time, there was an education campaign that was pushed out to all of our licensees so that they were aware of it. There was a lot of stakeholdering as well, so a lot of involvement from clinicians, and also our public members in support of that. So there was a lot of communication, and the intent of that was to simplify the rule process, the rules, so that it was easier for pharmacists to adhere to that. So I think there's no guarantee that every pharmacist that is currently in practice has read those rules, but I think most pharmacists through their training, and Jenny's certainly closer to this than I am currently, but most pharmacists in their training, this has been a part of our training and experience as pharmacists. Is obviously previously it was a 72 hours, but making sure that patients in urgent situations had access to care. So I think I would say that there's most pharmacists, working in a practice I would assume are very familiar with this. But
all right, Donna and then Jenny.
Hi, this is Donna. I would disagree with you, Tim. I imagine few pharmacists are aware of this, the ability to dispense a 30-day emergency supply. The other thing is, even if the pharmacists are aware of it, the company that they work for might not let them for specific liability reasons. So it's not necessarily just the pharmacist behind the counter. It could be, if it's a chain, a large national chain, they might have policies that prohibit the pharmacies from doing so. And the reason why I think that the pharmacies, it might be an educational thing or with the pharmacists is, we even have trouble with patients that are going in and trying to get emergency contraception, and the pharmacy doesn't know how to do that. So that's been a challenge, and how to, work. It would be great to work with Jenny and Tim, and how can we do more education and get the pharmacists aware of these new, I guess, advanced authorities that they have within their scope of practice.
Thanks, Donna. Jenny?
Yeah, I completely agree with both of them that we did do quite a bit of education, but it was at the height of COVID, and pharmacists, we rolled out these rules still when we were trying to scramble to dispense lockdown medications for folks. I mean, it just happened to be the timing, but I think that I'm committed to re-educating. I will even just work on language that goes out today to our pharmacy community. There will still be some barriers with the chains, and I will also work with our chain policy folks to make sure we can overcome some of that as well, because sometimes just education on that piece can help. So I don't want us to take any more time. For the rules are in place. It's not something this committee needs to do, but I absolutely hear about the barriers, and I'll work to help to overcome those.
Thank you, Jenny. And I don't see any other hands up, but I do have one question, Haley, for you. You mentioned that manufacturers are funding the Maine and the Minnesota programs, and I didn't see the funding source for either the Utah or the Ohio programs. I'm assuming Utah is fairly small since it is more of an access to the rebates, but was there something in the analysis that indicated funding sources for those other two programs?
Yeah, so when I said funding, I meant kind of indirectly, as in they're responsible for either backfilling the supply or reimbursing the pharmacy. There's also state funding for FTE to manage the program in one state, but there was no appropriation attached to Utah or Ohio in terms of like any FTE to run the program or manufacturer registration fees.
Very good, thank you. And Laura?
Yeah, Laura from the American Diabetes Association. I can kind of address the Utah program. So in Utah, they set up the purchasing program, and the way that works is people can apply. It's online. They have a website. It's a very streamlined, quick process. They get a digital card and they can go to the pharmacy. So when there's an emergency medication, so this was like the last step, this change that we did there, working with the bill sponsors, it allows them to actually utilize some of the insulin through the purchasing program to get to patients. So the pharmaceuticals are not being asked to reimburse those. So the state allows people who are uninsured. So that's the genius of the Utah bill. It had a copay cap for private insurance. It had a purchasing plan for those that are either in ERISA, high deductible plans. So kind of what Kevin was referencing earlier, there's still a lot of people that don't have access to affordable insulin in states. So those people in those ERISA plans and high deductible plans can still buy into the purchasing program in Utah. And it's been extremely successful. So and the state then has larger buying power, so they can buy the insulin on a larger scale to get people access. And the state, through the state law that was passed, the state can charge through the purchasing program just slightly, a very minimal cost to keep providing for the program. But they did not have to hire an extra FTE for this program because they had streamlined it so well. There was an original appropriations, which was a very small appropriation to stand up the program. And then after that, they did just incorporate that into the health department and running things through state current positions. But it's been incredibly successful.
Excellent. Thank you, Laura. We'll go to Lugina and then Jane.
Hi, this is Lugina. I just wanted to reiterate, I think Jenny did a really nice job when she was talking, answering the questions, is that on this chart that we're looking at, you have kind of two issues that are commingled in this one chart. One is the ability of pharmacists to dispense an emergency supply, whether that be 3 times in 12 months or whatever the case may be. So that's kind of down at the bottom with Ohio, and then what we talked about just now with Washington. Whereas the Maine, Minnesota, and Utah is really addressing the payment issue and how you fund this program. If I, so I think there might be a little distinction here between the first 3 rows and then the bottom row.
Excellent, thank you. Jane?
Yeah, so a suggestion and then actually a question for Laura about Utah. So in terms of suggestion, sort of keying off what Lugina just said, it looks like out across the 4 state programs, there are a number of issues that are addressed, right? There's cost sharing for people who have coverage, there's people who are uninsured, there's how the program's financed, and there's prescriptive authority. And so for maybe improved understanding, I would ask that the center maybe put together some sort of a table that lays out sort of in a column each of the different elements that we've discussed, and then for each state sort of just do a check mark or some indicator of how the state law addresses each of those elements. It might be an easier way to sort of compare and contrast what the states are doing and consider, and help think about whether that would be integrated in. I definitely agree that addressing Mary's question about how the insulin that's dispensed is financed. And it would also be helpful on Maine to get more detail about the criteria for the patient assistance programs that the manufacturers committed to set up. I'm assuming that there was a lot of negotiation around that. And it'd be interesting to see what parameters the manufacturers are putting on. And then Laura, just a question for you in Utah. So a person can quote unquote buy the insulin or get the same pricing for the insulin at the state sort of post rebate. Who's actually doing the fill on that? And so that's the one piece I'm not understanding.
Yeah, so that's a great question. So people can buy in and they basically are buying it in through the state employee plan in the sense that the state employee plan has a negotiated cost. They can purchase it at the state employee cost after rebate. And you go to the pharmacist and there's a code that they set up and the pharmacist bills back to the state employee plan for that. So that's how that works.
Got it.
Yeah.
Thank
and
you.
Because as the plan expands and the uninsured or those who have high deductible that are in ERISA plans can buy into this, then the more people that are in the program, the better buying power and negotiating power that the state has. And they have one in every class of insulin on it. So even some of the newer, more really rapid acting insulins are available. You cannot get it via vial. For those that need a vial, you can get an insulin pen. So they have it in several different delivery mechanisms as well.
And Mary, can I do one follow-up for Laura?
Yes.
So follow-up, how does that sort of post-rebate price compare to what the WAC or the list price is for the drug? I'm just curious.
Yeah, so in Utah, I believe the price for a 30-day supply is about $75. The last I checked, they may have changed that based on costs, but it's about $75. So they get what the employee plan price is through their purchasing program. So it is significantly less than list price. Now, it's not as low as a $35 copay cap, but it is significantly cheaper. And the state would have the ability, were another state like Washington to develop this plan, something similar, to set the price where they wanted to set the price for the consumers, especially the uninsured, to access to insulin based on, what their costs were and what kind of negotiation they were able to get.
Thanks, that's super helpful.
Great, terrific. So if Haley or Mike could answer Jane's other request around getting a separate grid, and then we'll go to Tim.
Yeah, I can definitely work on that, and we can send it out to all the attendees after the meeting. Thanks for that suggestion, Jane. That was really helpful.
Thank you, Haley. Tim. Tim, was your hand up from before?
I'm talking with the mute on, so.
Okay, there you are.
I was going to say, I'll post in the comments the WAC that references our ability to dispense emergency supplies. And we're a little bit different. I'm just looking at the content here. We're up to 2 times a year, once in a 6-month period versus some of these which have 3 times or others. But I'll post the WAC in the comment section.
Excellent. Thank you so much.
And I'll
All
just
right.
add on, there's a separate provision for if an emergency declaration for displaced persons, there's a separate one that's a little more lenient as well, that also is in our law. Just so you know, there's that backup too.
Very good. Thank you, Jenny Arnold. Any other thoughts or questions? I don't want to keep us too much longer before our 10-minute break here. All right, well, let's come back at 25 to 11, and we will at that point turn it over to Mike Veneno of the center. Back here. Thanks again for recording in process, and reminder before you speak, if you could please state your name so we can make sure we're capturing that for the purposes of recording. And with that, I will go ahead and turn it over to you, Mike.
Great, Mary, thanks so much. So guys, I'm going to walk. Oh.
Sorry, I just saw that there's a question in here for Ronnie. I don't know if Ronnie's still here.
I am.
Go ahead, Ronnie.
Actually, it's the other Ronnie. I'm sorry.
No, it's a different Ronnie.
Ronnie, sure.
Yes. Let me give Ronnie an opportunity to talk. Okay, Ronnie, you can speak now. You just need to mute yourself.
Thank you. My name is Ronnie Shore. I'm a retired pharmacist. Well, I pretty much failed at retiring, but I am the president of Healthcare for All Washington and have followed this issue and talked with many of the people here about solutions. I'm thrilled to hear the comments about developing, or the fact that an educational program is needed. But to build on that, I wanted to point out a couple of issues, which is that patients really need to be educated as well. Our Office of Insurance Commissioner has done great jobs on developing patient rights around areas, populations like this. So it would be great to pull in your office, Jane, to help define that as part of this educational program, educating pharmacists, not just about the law, but about access to insulin. Each of the programs that we reviewed in Minnesota and Utah and Maine and Ohio had educational proponents or resource components that patients could use that are available. It's so important to pull that information together. And for pharmacists, it's more than just the law. There are people with insurance do have trouble still getting insulin, but there are overrides that pharmacists can use, and there probably needs to be overrides for the institutions or the large corporations that pharmacists may be working for. I think Donna pointed out that there could be policies for employment policies that won't give the pharmacist freedom to do that. I think our state is in a great position to address those issues, but I think we need to pull in a lot of these other factors. So bottom line, I'm thrilled to hear we're talking about an educational program. I don't think it's going to solve all of the problems, but it can pull enough of those together that we can reach out and identify the individuals that really need to get this emergency supply, that really need to overcome these barriers. And it is an issue of saving people's lives. I don't want to be in a state where someone else dies from a lack of insulin. So I'm thrilled to hear this conversation, and I hope it will move to that next higher level. Thanks for letting me jump in, Mary.
Sure. Thanks, Ronnie. Mike, back to you.
Great. Well, Ronnie, yeah, thank you for your comments. Okay, guys, so we're going to transition to kind of this discussion and overview of survey number 3. So much like we've done the previous 2 meetings where we've shared the survey results, but then also have kind of this broader discussion. We want to do the same thing today. So we want to make sure that this is kind of the discussion forum, much like you guys were just having, but get into a little bit more detail with kind of those survey responses. So Ronnie, if we can go to the next slide. So just to give you an idea of kind of number of respondents, down a little bit from last time. So this is a little bit of a nudge. So if we do a survey 4 or survey 5, we would love to see that back up to 13. So really have everybody participating. So if you didn't do that, survey number 3, certainly there's an opportunity in today's discussion to weigh in, but really I think it helps everybody kind of see those responses side by side when we kind of go through this. Okay, so next. Okay, so a lot of text up here. We're going to kind of take this step by step. So this was the first question that when we outlined this survey, this was before we had done even additional work on Utah and Ohio. So when you see up there, it says both programs referring to Maine and Minnesota for purpose of this survey. Now, that doesn't mean the discussion today, right now just has to center on that. You want to bring in any additional thoughts on Utah and Ohio? Fantastic. But for right now, when we look at this, so both programs, meaning Maine and Minnesota, allow pharmacies to collect this $35 copayment to cover the pharmacy's costs of processing and dispensing. And then the question really is, what, if any, aspects of how pharmacies are paid for their service would you recommend including as part of the work group's report? So you guys have already touched on this a little bit. Kevin went through kind of a lot on just even that copay, and you'll see these initial responses. Everything that you see in bold was just our take of trying to kind of highlight some of the key pieces. And that was just us trying to do that. So if you wanted to highlight other elements, if you guys were kind of the authors of any of these statements and you want to highlight anything else, please feel free. But you'll see here, copayment should be de minimis. Then there's this comment of why the limit is set at 35. It seems arbitrary. And I do think it's worth some discussion on that, even right now. Jane brought up the comment earlier on that is tied really to a Medicare provision on that $35. And I think you have a lot of states looking to align with that policy. Doesn't mean you have to, but I think you're also trying to understand potential consequences of not having that alignment and what would that look like if it was below. So as long as pharmacy is made whole, including the dispensing fee. And then next, just a continuation of this, and then we'll get into some discussion. Importance of supporting more than just dispensing a generic insulin, ensure that supplies and time release insulin are available. You guys have talked about that several times in prior meetings. Emergency copay should be 0, and $35 is a lot. Any PBM and manufacturer rebates. A comment here, notification to prescribers is an additional burden for the pharmacy filling the prescription. Would not recommend that. And pharmacies need to be supported by the manufacturer through replacement stock or reimbursement. So again, when you think about it from let's just talk about this copay side. So what we have seen with Maine and Minnesota, the $35. I'd like for some others to weigh in. What are your initial thoughts? Knowing that we kind of have that alignment with what those states are looking at is having that alignment with Medicare.
Hi, this is Jennifer. So I work part-time as a nurse at community healthcare in Tacoma, and we work with people who sometimes are very low income. And I know that, luckily the other day we had a donated supply of glucometers, but there was an individual who could not afford their $10 portion of their payment for their glucometer. And so I just know that while I think for somebody that is on insurance and has the means, then $35, I mean, that's what it is. But for somebody who is really struggling, and I spent the first 20 years of my life in poverty, and $35 is potentially a lot of money. And so I think if we can lower that, it's worth doing.
Thanks, Jennifer. Others?
I just want to reiterate Jenny's comments too. I mean, having rationed insulin, like $35 can be a lot, especially when you're juggling like other costs, like your supplies that, you know, maybe aren't covered by your insurance. So $35 is like, it doesn't seem like a lot, and like all the other states are doing it. But again, this is like an added burden on already a chronic illness. So if we can lower it, it will mean a world of difference for people.
Hey, Kevin, have you guys thought about it being tiered in any way, that it would be, you know, a different copay, emergency copay for somebody who was uninsured versus somebody who did have insurance?
I hadn't really thought about that. I think that's an option. And I don't know if that would make things more cumbersome than just having a number straight across the board, but I do like that idea, that so that potentially somebody who does need it to be zero, it could be zero.
Yeah, having a progressive structure would really be helpful. I mean, I think the crux of like affording your insulin for the insured is, I mean, middle income people that are just kind of, again, on that elbow where it's like they don't quite have enough. So, I mean, having a progressive structure would probably be helpful, but I mean, again, lowering that cost as much as possible should be is my task anyway.
Got it. Thanks, Kevin. Tim, I saw you have your hand raised.
Yeah, this is Tim Lynch. I think, you know, having a progressive copay certainly is great. I just, so long as the pharmacy that's delivering the service is made whole in total. So if there's, you know, a progressive, you know, rate that's charged based upon income, I think, one, we don't want to add complexity to the process. So if the copay is a burden, I think so long as there's a way for the pharmacy to get recoupment of that, because this is not just a standard situation. As the patient walks in, they don't have an active prescription, maybe they don't have a bottle in hand. There's going to be additional screening that the pharmacist has to do in order to ensure that the patient's appropriate. There's the documentation that's been mentioned in the other laws. So there's a lot of work that goes into these cases, and the pharmacies need to be made whole for that. I think the pharmacies want to deliver the service, but so long as there's a way to make sure that they're made whole in this process, I would advocate for that.
Thanks, Tim. Jane, I saw you have hand raised.
So Mike, a couple of thoughts. First, if you're going to think about tiering, then I think you pretty much need to use an attestation process, because we should not be asking pharmacists to ask people to show like their pay stub. Right. That's crazy making. So if people are comfortable with an attestation, then I don't know that there's any other way that's feasible to do kind of a tiered cost sharing structure. Because if I were a pharmacist, I sure as hell wouldn't want to be put in the position of having to do that evaluation of somebody's income.
Right.
I'm trying to fit the jigsaw puzzle pieces together. And this is why I asked for that table earlier. When we're talking about $35, first of all, I'm thinking at some point we're going to have a discussion about whether we're talking 30-day, 60-day, 90-day. And so what I don't understand is when we're talking about reimbursing the pharmacist costs, there's sort of the administrative cost. What's the administrative cost for a 30-day supply as opposed to a 90-day supply, right? If it's the pharmacist just having to do one dispensing, but instead of dispensing 30, you're dispensing 90, how does that factor in? Because $35 for a 30-day supply and $35 for a 90-day supply is pretty different. So, like I said, it's fitting the jigsaw puzzle pieces together. Sometimes it's hard to discuss each of the elements in isolation, and maybe at the end, sort of going back and revisiting, okay, where are we and what does the puzzle look like when you put the pieces together?
Thanks, Jane. I would welcome others to weigh in on that on the pharmacist side. Yeah, Donna.
Yeah, I mean, from a cost of dispensing perspective, as a plan and a payer, if there's a dispensing fee, we would pay the same dispensing fee for a 30-day supply as we would for a 90-day supply. If we're talking about cost sharing, that's a different story. So Jane, I wasn't sure if you were talking about the dispensing fee that the pharmacy receives for the overhead cost of actually dispensing the medication versus the co-insurance.
So I think what I was referencing was, and Mike, can you go back a slide? Is that doable? Dispensing and processing fees, right. So if the idea is to use the copay that the individual is paying to cover the dispensing and processing fees for the emergency insulin, then it seems like having the discussion about whether we're talking 30, 60, or 90-day supply is important. Does that make sense, Donna?
I think so. And Jenny, I think, had her hand up, and she can probably chime in too. I mean, I don't want to put words in the mouths of the pharmacists, but I can't imagine the cost of dispensing being more for a 90-day supply than it is a 30-day supply, other than, counting. You might have to check 3 boxes to make sure you have the right product instead of 1. So it would just be the amount of time it would take to, check the additional quantity to make sure it's the appropriate product that's being dispensed. And I can't imagine that being a significant amount of time, at least not in my experience.
Let's go to Tim and then Jenny.
I think Jenny might have been first, but I would agree with Donna. The difference between a 30-day and a 90-day dispense, the same administrative work that is required would be the same. So I wouldn't see that as, I would see that staying the same.
The biggest factor that would be different would be just the taxes paid on the product. It would be 3 times more. And that's not an insignificant amount. It's about 0.5% of the cost that's charged to the pharmacy. So it's not insignificant, but that would be the biggest variable between doing a 30 and a 90-day. Checking 3 vials of insulin versus 1 is, that's not significant. And three labels versus 1 is minor as well, but the taxes, I think, would be the biggest difference on that.
Thanks, Jenny. And Jenny, you would consider that tax as part of this processing, cost. Yes.
It's generally factored into the cost of dispensing. Yes.
Yeah.
And I think we could factor that into an overall cost of dispensing that would work, but I think a 90-day solution versus a 30 is a logical place to go on this, and I think even more significant for tearing down barriers. This may be jumping 3 steps ahead, but it seems to me like we'd put in place kind of a dummy bin number for this for processing through a system through the state, where we fund it somehow and come up with the insulin somehow and be able to manage it. So the pharmacy basically runs it through a state program, the same as they would if they were billing Medicaid or an insurance company, and then where the administrative burden would be then on the state for managing and kind of coming up with the payment for that program. Potentially that seems the easiest. Then you could be able to track which patients used it, how often they used it, that the state would be able to own that eligibility process versus the kind of individual pharmacist, which would not be well equipped to do that.
Thanks, Jenny. Yeah, Tim.
Yeah, I just want to make sure we're clear. to dispense a 90-day supply, it would have to be an active prescription that is valid currently, and it wouldn't address the emergency provisions that we talked about before. So that's limited by WAC as a 30-day supply currently. So we just would have to factor that into the conversation if the intent is to go 90 days versus 30 days. Emergency versus you got an active prescription. So.
Okay. So let me just, I want to keep poking on this then. So to Jane's point, let's say this $35 is there and it can cover this processing, dispensing. But if it was for 90, then Kevin, I mean, that then gets broken down to almost like under a $12 copay per month.
Yeah, that's what's going to be my next question is if we're talking about $35 and everybody else is doing $35, but they're at a 30-day supply, whereas we're talking about a 90-day supply. So how are we going to recoup that difference? Because it seems like, yeah, again, it's like $12 per month as opposed to 35. So I just wanted to be really clear on how much the patient is spending. $35 for a 90-day supply is great, but that's a lot to cover for the pharmacy.
Well, I mean, either way, it's not covering the cost of the insulin. That has to come somewhere else, right?
Yeah.
Yep. Thanks, Kevin. Other thoughts, comments here? We're gonna hit on this again. The 90-day is brought up again. So we're not done with this just yet.
I mean, I think the 35 versus the 30 versus the 90 is honestly probably too far into the weeds because we haven't even set up what the program is, who we're impacting, what the solution is we're trying to solve. On previous calls, we said we saw two different buckets of helping the uninsured versus helping the insured. And those are two different, to me, because they're two different solutions that you need to address. I think we selected as a group that we were going to help the uninsured. I feel like we're going around in circles and talking in high levels, and maybe it's if we bucket them, then we can kind of decide, is it a copay assistance program versus is this truly, insulin for uninsured individuals or those lacking maybe under and uninsured, and maybe include those who have high deductible copays. But what does this program look like? What is the problem we're solving? I think maybe makes sense versus getting into the nuances of 30 versus 90 or 35 versus 30 or.
But part of it, go ahead, Kevin.
Sorry, I just I thought we'd already decided to prioritize the uninsured, but that our recommendation was going to be for both the uninsured and the insured. We're not doing either or, we're doing both. But
I think it's a start and then a second was more maybe where I was, come up with the solution for one and then we can work on the solution for the second was kind of where I had it, but I think that kind of sounds the same.
Perfect. Yeah.
And the one thing that I would just kind of bring us back to is what you guys are tasked to do kind of within the legislation. So, and this is kind of specific to say, you guys were tasked to review and make a recommendation on the 30-day. And so you really are talking about the emergency supply as a short term. And then you're also looking at the long term, like what are we doing kind of long-term cost savings? So Jenny, when you talk about the two buckets, those are the two buckets that we're actually trying to address. So you're really trying to analyze, okay, what are your recommendations to the legislature for revamping or implementing an emergency supply program? So we're kind of, does that make sense? Yeah. So within that, you're right. You kind of get into different populations and what that could look like. And so what you guys have almost immediately started to weigh in on was, hey, I'm not sure that 30-day feels right? It almost needs to be longer than that. So again, that could be a recommendation that you guys would put forward to the legislature, right? We've got, you asked us to analyze the 30-day. We're not certain that feels right. We may want to push that up more, but that's going to be, again, kind of that group discussion.
Ronnie has a question. Ronnie, go ahead and unmute yourself.
It was really just a comment that
I'm sorry.
We are talking about life and death here. We have made public health emergencies for COVID, and in order to ensure that patients pick up their antivirals to prevent COVID or to prevent the spread or prevent death. Is this another public health emergency? Would an issue that this group can work on is funding this copayment rather than struggling with $35 versus a separate copay for $90 supply. I think the bottom issue is life and death here. I just wanted to add that comment. Thank you.
Ronnie, thanks for that. Before we move on to the next one, I did want to hit the second to last comment. The notification to prescribers is an additional burden. I would love just some additional thoughts on that, because that was a provision that was called out in one of the states, and I just wanted to kind of get your sense of that. Is that something that you would recommend or not?
Hi, Mike, this is Donna. I think I'm the one that made that comment. It is just, and Jenny had to drop off, but what's the purpose of notifying the prescriber of the dispensing? You're also going to be requesting the prescriber, if it was an expired prescription, you would be notifying the prescriber requesting a new prescription. And renewing that prescription. So I'm not sure what the purpose of having to notify the provider does. I don't know its purpose. And Tim, go ahead.
Well, this is Tim Lynch. Don, I think you and I probably had the same exact comment. I was the same. I didn't, one of the things that bothered me about the other states' laws was creating artificial burdens for pharmacists to provide this service. And unless there's a real strong reason for collecting certain data elements and a justification for what that's going to do to support the program or enhance the program, I found a number of things within the rules that other states had put forward that just seemed to be an artificial barrier to providing the care that I think everybody wants to do. And I would caution us against having similar language.
Got it. Thanks, Tim. Lugina.
Hi, this is Lugina. I just wanted to ask a clarifying question. The notification of prescribers, and I don't remember it from the chart a couple of slides earlier, but is it in Maine and Minnesota, is it when the pharmacist dispense an emergency supply to help the patient not have a disruption in therapy, that is it just kind of after the fact, they've already dispensed it and it's just kind of like, FYI, Dr. So-and-so, we dispensed this over the weekend for your patient. Is that the burden, or is that what we're talking about?
That's, that's I think what this provision basically does, because if the notification is after the fact in both of those laws.
Okay. And I'm just trying to figure out, generally, I think that those provisions, I served on a board of pharmacy as well in my previous profession a couple years ago, but I think it's more of a continuity of care issue. And I think if you look at the language that Tim shared with us on the new rules for pharmacists, there is the element that it looks like provision E, where the pharmacist has to communicate to the prescriber within a certain amount of time after doing an emergency fill. So I always figured I always looked at this as, yes, it's a burden, but it's also to make sure there's continuity of care, that the provider knows that the pharmacist has done this in an emergency or urgent situation. And you can also reach out if you need to get that new prescription for the next time.
Yeah. Thanks, Lugina. Yeah, Tim.
Yeah, I was just going to say, if the patient's already on a prescription that the pharmacist is providing an emergency supply of because they can't pay for it or whatever, then the notification just, again, I go back to, I think in the case of the emergency prescription, the refill, these are refills that are no longer active. So I think that goes to the continuity of care to make sure that, I dispense this prescription, it no longer had any refills, and therefore I'm going to dispense it again to ensure that the patient's covered, versus this where this is an active therapy that the patient's on. So I just would say, to the extent possible, if insulin is generally not something that people are going to abuse, and therefore I would argue that lowering those barriers for pharmacies can certainly I think we just need to do that as much as possible.
Tim, thank you so much. I didn't appreciate that nuance of creating a requirement for the pharmacist to inform the physician of generally just refilling a prescription on an emergency basis. So I really appreciate you explaining that nuance.
Thanks, guys.
And Mike, so this is Don, I want to jump in. And the emergency might be that they can't afford their prescription. It might not be that their prescription is expired or they're out of refills. And so you're notifying the prescriber that they had to use this patient assistance program this month to afford their medication, rather than going through their normal insurance company. And so that's a slight nuance as well.
Great discussion, guys. Thank you. Ronnie, let's go to the next. So next question, again, looking at Maine and Minnesota, both bills allow patient access to the emergency 30-day supply to once in 12-month period based on a completed application. So the question, what, if any, aspects about this verification process would you recommend including as part of your recommendation to the legislature? So you'll see a number of comments here, just understanding, so what is this process? We kind of talked about it earlier. Haley kind of walked through, that application submittal. And then you guys kind of weighed in. I don't think it should be limited to state residents with ID, available for undocumented, use ArrayRx to the extent possible. Next slide. This has been brought up, obviously, ensure patients get ongoing supplies, minimal verification process, notified of other health insurance programs like we heard earlier. But I also wanted to go back to Kevin. Kevin, in your opening comments, as you kind of went through patient perspective, and you talked about your recommendations, you talked about loosening eligibility criteria. Can you talk more about that in terms of what this looks like to you? I mean, what does that mean, the loosening of, if you had your...
Yeah, so I think in my comment, I have a couple comments in there. I mean, I've tried to help people who are from out of state, and they get here and their insulin vial breaks and now they're stuck. I mean, if they were going to try to access this program, they wouldn't be eligible because they're out of state. So I've helped a homeless person get insulin, like they don't have ID. The process for them to get an ID takes a while. So as many barriers to entry as there are, we have to look to mitigate those. And for me, that would be what that looks like is you go to the pharmacy, you fill out an application, you don't need to show ID, and you can use this program numerous times. I can foresee breaking my insulin vial more than once a year. I'm a clumsy person. I could easily drop it and then I'm stuck if it's a Friday. There's so many reasons, again, why we stated why people have coverage gaps or why they don't have insurance to begin with, why they can't afford their insulin. When they have insurance, there's so many reasons. So loosening the eligibility criteria, I think what that means to me is someone puts down their name. There's an indicated urgency of need. I think that's built into some of the other programs where the pharmacist can assess whether or not this person needs it. Again, I don't think anybody's going to be abusing insulin. And this is like a clear, you need it. And then we track, how many times this person uses it, why they need this, so we can have some survey data as to the root causes of this. And then, potentially Also include education materials to sign up for other programs, like if they are undocumented, how can we get them documented? If they're homeless, can we, provide them with social services? So I think there's a lot of like points of entry right there where you can have them access some of these social programs that we talked about, so that we can get them covered, so that they don't have to rely on these programs. But yeah.
Got it. Thanks, Kevin. Jennifer.
Yeah, I think it was Jane who brought up the attestation earlier. And I think it seems reasonable, you want to try to make sure you're tracking for financial reasons or whatever. And I know that that's going to be done in some format. And so I think it's reasonable to ask for an ID, but maybe not have it be required. And at that point, if somebody, I don't have my ID, I left it or whatever, then maybe some type of attestation could be done.
Thanks, Jennifer. And Haley, I'm just thinking of Jane's earlier comments. I think this is going to be one too that would be helpful to we'll see on the grid. We can kind of see that side-by-side comparison from the states, and then we can kind of have a better understanding of, what's going to be potentially the best fit for Washington.
Okay.
Other thoughts here on eligibility criteria? Okay, let's go to the next. So Haley highlighted Maine, and the way that they were looking at funding this was through this manufacturer payment. So those who sell or distribute more than 500,000 or more units pay this annual $75,000 annual registration fee, which is funding that full-time FTE. So just kind of curious on your thoughts around when you think about getting a program like this up and running, what are your thoughts around funding it in this way? And you see kind of what those initial responses were from the survey. Possibly some post-enactment challenges. Obviously, $75,000 could pale in comparison of what the manufacturer's profits are. Fee to manufacturers, it can have a negative connotation. If they are actually paying for this, is that seen in a negative? Better than using state funds. And yep, thanks, Ronnie. Lugina, I saw you had your hand raised.
Thank you. This is Lugina. Mike, I just had a real quick question. The $75,000 annual registration fee in the main program is one element of the financial support. And then there's also the requirement that the manufacturers replace the insulin that's dispensed. Is that correct?
And I'll look to Haley, but my understanding is that that's absolutely correct. Yes.
Okay, thank you. I just want to make sure.
Haley, you would confirm that, correct?
Yes, that's correct.
Yeah. And again, that you could be having obviously more than one manufacturer, making that payment of $75K. Jane.
So I think, Haley, it would be really interesting, and Mike, to go back and talk to the folks in Maine. There was obviously a deal cut, right? The use of the patient assistance program, $75,000 annual registration, replace the pharmacist supply. I'm trying to figure out how the patient assistance piece fits in. Is this so the manufacturers could do a tax write-off and call it a charitable donation? It just seems like if this is the path that the group wants to go in its recommendations, it would be really helpful to sort of have an understanding of what the political dynamic was in Maine when this was being discussed.
No, Jane, I think it's a good call out, because I think I saw the same thing. When you see that 500,000, that's a number, right? That's a target. And if it's funding one full-time, well, you can kind of start doing the math of how many manufacturers that's going to, apply to, right? So I'm sure there was some deal cut. So I think it's a fair follow-up on our end. William.
Yeah, I completely agree with what Jane indicated. We have to be careful with building these programs and obtaining the money from the manufacturers. But as a representative from an entity that participates in a program that has that works with a manufacturer, where we built an agreement to obtain medications at a lower price, and runs a program that is completely government funded, I think we need to find ways to limit the use of state funds to pay for this. And if we can be creative and find ways to have to get money from those entities that are creating this challenge for our patients in the end, it would be nice to be able to seek funding from them. So I'm interested in finding out more information as well.
Thanks, William. We'll do. Other thoughts, comments on this? Great, thanks, guys. Okay, Ronnie, let's go.
Sorry, I do want to have I have a comment, just because I think anytime that you're taking money from somebody, there's going to be, like Jane mentioned, it's a deal. And so I don't want somebody from the pharmaceutical company being the person in charge of this program.
Thank you, Jennifer Perkins.
Thank you.
Thanks, Jennifer. Okay, so next one, both bills, again, Maine, Minnesota, require manufacturers to reimburse pharmacies with backfilled supply of the emergency insulin dispensed, or reimburse monetarily for the dispensed insulin equal to the pharmacy's acquisition cost. What, if any, aspects of this reimbursement or replenishment model would you recommend including as part of the report to the legislature? You'll see what we have down here. Again, now, many of you might not have responded. So whether you did or didn't, I would love to hear people weigh in on this. Reimburse pharmacies with backfilled supply of the emergency insulin. Should be an accounting of the supplies and effort. Leave it up to the pharmacies. Manufacturer paying pharmacies acquisition costs or to replace the supply is a good option. Support a monetary reimbursement model so long as it is timely. Remuneration is included for the pharmacy and a dispensing fee. Pharmacies should be paying the copay fee too. Thanks, Ronnie. Can you go back just the next slide so they can see? Yeah, thanks. So initial thoughts, comments here around how this should be set up with manufacturers reimbursing and backfilling.
William Hayes has his hand up.
I know, William, was that from last time?
Yeah, actually it was, but I will comment as well. I think any model where we can utilize the manufacturers is great. So whether it's direct funding or replacement or rebates, I think I would support anything that works well for us. But again, we have to understand where the political ramifications and the deal making is transparent. From my role in ArrayRx, as well as with DOC, we want to make sure that everything is clear and open to those that are involved in all of this. So we want to make sure that it's a good process, and in the end, we're ensuring that the people of the state of Washington, in particular our patients, are the ones that are getting the best care from what we're doing here. So I'm glad I had my hand up so I could speak, but I liked all of these ideas, but I think we as the work group need to find what works best for us.
Got it. Thanks, William. Tim.
Hi, this is Tim Lynch. I would say I don't think we need to pick one option. I think we could use a menu of options and let the pharmacies opt into what's best for them. I think, again, lowering the burden for the pharmacies to be able to provide this service and letting them pick, if they want reimbursement or they want to use their existing wholesalers to supply it and get monetarily reimbursed, whatever that looks like. I think, coming up with different menus or rebates, as someone mentioned, I think that would be the ideal state for me, so that we're not trying to fit everybody into a single solution. A lot of, a large retail chain may have an entirely different infrastructure available to them to be able to facilitate something that's easy for them versus a small rural community pharmacy that has one person who's the pharmacist and also the buyer and the purchaser who has to do all the paperwork behind the scenes. So I think leaving it up to the pharmacies to determine what's best would be a good solution.
Okay. Thanks, Tim. Mary.
Yeah, Mary Fliss. So I would just add that we should be aware of the nuance of other manufacturers that may come to the market. So if we have the opportunity to buy from the state of California, say, and they are offering insulin at a significantly reduced price, I think we need to be careful about how we would consider participating in that sort of a program in the context of this.
Got it. Thanks, Mary. Other thoughts, comments from pharmacists out there? Okay. Ronnie, let's
Mike,
keep...
do you see Leah's hand up?
Oh, no, I didn't. Sorry. Leah.
No worries at all. Thank you, Leah Lindahl with the Healthcare Distribution Alliance. Just for reference, I think we would agree with Tim. I think the devil's in the details as far as kind of how the legislation would look or the language, and probably best to leave it up to the pharmacies and how their kind of individual kind of contracts work. But just wanted to reiterate what Tim had said.
Perfect. Thanks, Leah. Appreciate it. Next one. So kind of just final thoughts as you think about Maine and Minnesota. And again, I would open this up for Utah and Ohio as you think about what you heard today from Haley's overview related to insulin. Any other recommendations? And I guess I also want to frame this knowing that we'll come back at meeting number 4 and I think take Jane's recommendations to heart with a more maybe detailed grid where you can start to see side by side and almost have a placeholder for Washington of really what you guys would want to see kind of populated. Then that could start to frame up what you could potentially have in that report. So anything else that you see here that you'd like to add on kind of for a group discussion today?
Lugina, I see your hands up.
Yeah, Lugina, thanks.
Hi there, this is Lugina. I was just wondering if we could add, you talked about the additional detailed document that's going to be put together. I'm just wondering, can we segment out the patient out-of-pocket cost for each of the programs when they're using it versus the pharmacy dispensing fee? I'm a little confused about the main element, and I need to read it a little bit more closely, but there was the $35, but I'm not, is that the dispensing fee for the pharmacies or is that the patient co-payments or cost sharing? So I just want to make sure that we're comparing apples to apples.
Agreed. And Haley, I don't know if you have thoughts on that, but yeah, I think that's a fair call out that we'd include that in that grid. Haley, did you want to weigh in?
I was trying to pull it up, the specific bill language, and I don't have it yet. I believe the $35 in Maine was specific to, hold on just a second, I'm almost there. in order to cover the pharmacy's cost of processing and dispensing the insulin. That's the language in the bill. I am not an expert on co-payments and how pharmacy dispensing fees work, but that's the language, if that's helpful at all. And then the manufacturer was responsible for refilling or reimbursing for the acquisition cost of getting the drugs. So that's kind of how it's divided in the bill language.
Thanks, Haley. Ronnie, can we just go through? Oh, Jane, go ahead.
So just one quick thought, Mike, in terms of structuring this options kind of menu with that via the table. Like I'm thinking of, we've been talking about emergency, but the Utah program isn't an emergency program. The Utah program is sort of, right, it could be ongoing in terms of somebody's choosing to take advantage of the pricing that's available through the Utah program. And so trying to make that distinction. And the only other question that I think would take some, maybe even some legal research is that Tim referred to, well, if you're going to do 90 days, that's inconsistent with the rule, the Pharmacy Quality Assurance Commission rule that caps the emergency prescribing to 30 days. So a question is, would you need some sort of statutory authorization if you were going to go to a 90-day concept? So just to take a look at that.
Yeah. Haley, just on, Jane just mentioned Utah. I just want to make sure we're clear on Utah. It's two separate provisions.
Right. I was going to say, yeah. So I want to make clear that the piece of Utah presented today was just supposed to be the emergency authorization, which is a separate statute than the discount program. We are thinking of the Utah discount program as a long-term solution. So it would be grouped with the ongoing patients assistance programs in Maine and Minnesota, and then the ARX solutions that we talked about in a previous meeting. But we can put together a similar table for long-term solutions. But that's why we didn't really dig into that portion today.
Kevin Wren, just a quick question on top of that grid. Would you be able to include maybe like a detail about how many full-time employees the state has to address this?
Yeah.
This is Donna. What would that tell you?
I'm just curious about like the state's commitment to it as far as a long-term solution, because when we looked at it, we were thinking like something like 4 full-time employees and like an actual department for our recommendation. But I'm just curious as to, I guess I'll just do that research.
Well, I guess my question is, I might be able to answer your question, but I'm not sure what you're asking. Are you asking how many employees are in the state of Washington, or how many employees are dedicated to this work?
How many are dedicated within Utah and then also Minnesota to address this? Because I'm just wondering about the government footprint as opposed to like our recommendation of 4 full-time employees or whatever that might look like.
I think in Utah it was 0. This is Donna.
And Kevin,
go ahead.
Yeah, Kevin, this is Mary. I think it's a really interesting question. And I sort of thought when you made that proposal, you sort of lined out what you would ask the staff to do. And I'm not sure the expectations that you lined out, we would have to match that also for comparison purposes to another state. And I'm not sure that what you described is what we've heard as in place in any of the other states. It sounds actually that Maine put it on the manufacturers to create that sort of patient outreach and assistance program.
Yeah, I'm curious as to know what other states are doing, and that's something I'll look into and try to figure out.
Thanks, Kevin. And we'll do the same. And obviously we'd want to match that with population size and all that, right? So we've got a better understanding. Yeah. Donna, did you have your hand raised before or no?
I did. This is Donna. I was responding to James' comment about legislation. I think we'll need legislation on, I know we have the emergency supply already, but if there's going to be a specific emergency supply of insulin, whether it be 30 days, 90 days, whatever number of days, I think the legislature is going to have to pass a rule and fund it somehow.
Thanks, Donna. Ronnie, can you hit the next few? Because I think this is a continuation. Oh,
Leah had a comment.
Sorry, Leah, go ahead.
Oh, no worries. I put it in the chat again. Leah Lindahl with the Healthcare Distribution Alliance, just saying that usually in the state legislation, you can look up the FTE total in their fiscal notes. So that's an easy resource to find the question that Kevin had.
Thanks, Leah. We'll definitely check that out and include that. Okay, so just a few more comments here from this question, kind of overall. 90-day supply, access more than once a year. Pharmacy should not have to notify prescriber. And again, 90-day. Things that you had touched on. Next. Greater flexibility and more than once a year. Greater flexibility for patients under 18. Repayment to pharmacies occur within 10 business days. Not include rules requiring pharmacies to retain copies of patient applications, much like you guys had talked about before. Anything else that anybody want to add on there? I think you guys had covered a lot of this. Okay, and I think we just have one more, Ronnie. Any additional feedback? So, yep, you guys have been talking about the inequality for a while. That's why we're all here, right? And having an easy process for consumers. So, great. So, a lot of feedback. This is great. I wanted to frame up again what we had talked about earlier. You guys did talk about different populations: uninsured, underinsured versus insured. And I think, again, we were trying to stay kind of clear with the legislation of you guys being tasked to look at, how could or should the state look at a 30-day emergency supply, which is getting into this discussion. And then also what's the longer term kind of cost savings path, which we had talked about at the prior meeting, looking at some of the other states, whether it's California, looking at certainly Array RX and that's in its capabilities. So we want to start even narrowing that down over the upcoming meetings. We've got kind of 2 more laid out. I think, again, Jane, great idea with this grid. I think the grid is going to help you guys get your head around that emergency kind of options, policy options, and then starting to package, that together with what's going to, again, be the best fit for Washington. And I think, Haley, you mentioned it. I think we can start to think about something similar on the long-term side as well. So you can start to see kind of that side-by-side comparison, and again, start to pick out what's going to be the best path for Washington. So again, this has been great feedback today. I think that is it on our end. Mary, we want to switch back over.
Sounds good. Just any other questions or comments? Thank you again for all of those who participated in the survey. And I think we're now moving to our poll everywhere.
Thanks for that reminder. We do have the poll everywhere. So we did want to just to follow up. So it's always nice to be able just to quantify a few things after a discussion like this. So we've got some good feedback and some subjective comments, but we want to see what we can do to kind of put a little bit more of some numbers behind this. So like we've done before, we've got this poll everywhere. So you can just, in fact, we can either put that in there. Ronnie's ahead of me in the chat. She put the link in there. So pollev.com/CBP OHSU 300. And again, you can put yourself down or not. You can be anonymous, your call. So I'll give everybody just a second to do that. Okay, so let's go to the next. So let's be the first question. So just on a scale to 5, with 5 being strongly support, how strongly would you support a co-payment not to exceed $35 for emergency supply of insulin? Do we have 100% right now for strongly support? Give it 1, 2, 3, 4, 5. Yeah, Ronnie, go ahead and you can lock that. I think we're pretty clear. Awesome. Thanks, guys. Let's go to the next. On a scale of 1 to 5, with 5 being strong support, how strongly would you support eligibility criteria that includes being a Washington resident to access an emergency supply of insulin? Okay, a little more split. Well, that's in it. Okay. Give folks a little bit here. This keeps moving on us.
Point of clarification. Are we talking a legal resident of Washington or a resident of Washington?
Resident of Washington.
So it would cover undocumented.
Correct.
Oh, okay. That might have shifted my thinking on that vote.
I wanted to mention in the comment, I think Tim wrote that he wasn't able to access the poll, so I'm not sure if everyone was able to access the poll for the first question, or I don't know.
We can go back to, sorry, Tim.
Chrome, I had trouble using Chrome, so.
Yeah, it took me a minute to get on too.
Yeah, so I missed the first question.
Yeah.
We can go back and open it up too.
Oh, text. Yeah, I'm still trying to log in here, so I'm super slow. Sorry.
No worries. Okay, let's go to can we keep going? We'll keep going to the next. Let's just keep that open right now. Ronnie, we won't have to lock anything.
Ready for the next one?
Yeah, let's
just a sec. I apologize.
Okay, no problem.
Voting polls. Is it survey? No. Never mind. Go ahead. I'm technology challenged. I just cannot get on it. So.
Are you doing it through your phone right now?
I tried to do it on my work computer and they're blocking it, so I'm trying to do it on my phone, and it's taking me to some funky website that's not the right website.
To me, the easiest thing on your phone is to just go download the Poll Everywhere app. And then you just type in that CEB and it's way easier.
Okay, go ahead and move on.
All right. Well, if you have time, we can always go back. It's truly not a problem. Okay, Ronnie, yeah, let's hit the next one. On a scale of 1 to 5, with 5 being strongly support, how strongly would you support requiring manufacturers to pay an annual registration fee if they sell or distribute a certain volume of insulin in Washington? A little more mixed, okay. With all the caveats that you guys put forward before, I think that's helpful to know. Give folks just another few seconds here. And okay, Ronnie, let's go to the next. We don't need to lock that yet. We'll just yeah, thanks. Tim, how's it going? So the last one we have here is open. So what other key takeaways do you have from the reviewed state legislation that the work group should consider? So again, a lot of discussion today, I think very fruitful, very needed, but anything else that stands out that you want to just even call out here? The requirement of manufacturer reporting. So whoever wrote that, I want to clarify. So that you're saying that is a good thing?
Yes, this is Mary. I think that was a good thing, and particularly given the discussion we had around not notifying providers and wanting to make sure it's not a huge burden to the pharmacists, but there is something about making sure that we are monitoring and tracking how the program is working. And so just if it's not coming from the pharmacies or from other, if we need to have a source of information in order to make sure we're managing the program.
Yep. Got it. Thanks, Mary. Two buckets. Yep. And I think we will start to frame that up. So thanks. Who said that? Yep. Easy to use. Consumer, pharmacy, state, and insurance. Yep. Great point. Haley, that's something to think about even with that grid too, right? Almost like an ease of use category, like how we want to define that.
Okay.
Anything else, guys? We started looking at long-term solutions, not just these short-term ones like the copays and emergency supply. Yes, and we're going to get back to those long-term solutions as well, even at our next meeting. But this meeting really was dedicated just to this emergency supply issue. Yep, have to create marketing, educational campaign for healthcare providers and patients alike. Yep. Tim, did you get in? No. Okay. All right. I'll stop bugging you. Anything else? Great comments, guys.
Does Tim have anything to add over the phone that somebody else could type in?
We can, yeah, fair.
No, I'm good. Thank you very much. I appreciate it, Donna.
Okay. There should be a standard, easy to use registration system if it is selected to be used as part of this program. Yep. Everybody have their comments in? Okay. Great job, guys. Ronnie, I think we can go to the next slide. And now, Mary, I think I'll turn this over to you. Thanks.
All right. So next steps. Thank you so much, everyone, for participating in today's meeting. We will take the comments and the feedback that we received, create a summary, as we know also that this presentation will be made available, as well as the transcript. And that usually takes us a little while to pull all that together. So appreciate your patience with that. We'll be continuing to work with the center for developing the next phase of our meetings and really making sure we have information to create our report out to the legislature. And our next meeting is again 3 hours. It's on Tuesday, December 6th. And we'll be then after that, we should have, this was as Mike mentioned, this was really focused on that 30-day emergency supply, looking at how other states have solved for that problem. The next we'll be looking at more of the long-term solutions, and then we'll be working on drafting the legislative report, and we'll have another meeting then in the spring of next year, and we will be turning in our report on March 31st. So, and just so we're setting expectations appropriately. The review cycle for a legislative report has many pieces to it. We make sure that we have subject matter experts looking at it. We have our communications folks looking at it. We have our our leadership and our policy people looking at it. So we like to build in time to make sure that we have a very polished product for the legislature. So of course, this team will be the brains behind that report, but we will, even though it's due on the 31st, we're not able to like take all of your edits up to the 30th, right? This is something that we'll be laying out a timeline for the report and making sure everybody has very clear expectations. And we do take a considerable amount of time to make sure we have it all righter than rain before we send it on to the legislature. Donna, anything else that you would think we should add? Mike, others, anything else for the good of the order here?
I don't. I think thank you, Kevin, for putting together the videos. Thank you, Jennifer, for sharing in your video. And thanks everyone on the phone for participating. I think it's a great conversation. Really appreciate the collaboration.
Yes, agreed. And thank you, Jane, for filling in. And Tim, welcome again to the group. And we look forward to seeing you on the 6th. Take good care.
Thanks, guys.
Thank you.
Thanks.
Mhm.
Bye.
Bye.